thank you everyone who participated today. This was our first ever virtual seminar. We had over 330 registrants, so that's unbelievable. And we also had a very steady crew throughout the entire day. But it's a big step forward, I think, into doing these kinds of seminars. And I know we had some technological issues, but they were a lot fewer than I was afraid of. So what we're going to do today, and I know the audience is in listen-only mode. If you really want to ask questions, you can go into the chat box and put your questions. You can also call over to Mandy Kaplan and give her your questions or email her. We're going to start at the beginning. We're going to skip the first session because that was the regulatory update, and they had their own question and answer. If you missed it, I would definitely get on and listen to it. There's a lot of very interesting information. Each session is going to have about 5 to 6 minutes. How we're going to do that, it's like a smorgasbord of information, but we're gonna move it through. Everyone should try to be succinct, which is not my ideal way to do things, but you have to do it. And we're going to see what we learned from COVID and apply it. So some of the questions are going to be more practical. So on my screen is a whole bunch of panelists, and hopefully when you talk, the GoToMeeting will move your face forward. So the first session that we're going to talk about, and if you didn't listen to any of the sessions, don't worry about it, because I'm going to give you a synopsis, and at the end I'm going to tell you that there's going to be a link that's going to come out by tomorrow morning, and it's going to have all the presentations, so you can listen to anything that you missed to your heart's content. So the first session was emergency communications learned during COVID. I love this session. It really kind of drove home the importance of communicating with your patients and staff, not just about facts, but also in being inspirational, which is something we all could use very much these days. So for those questions, we have Brandon Daniel, who's the president of Dialogue Health, and Chris Kralnick, who's the center administrator for the Digestive Health Center of Plano. So Brandon, let me start with you. During your comments, you talked about how as a company, it's your mission to get people communicating in a more efficient way. But is it possible that you could over communicate these days? I know I get so many emails, I skip half of them. Is that a risk?
That's a great question. And yes, communication fatigue is something that's real. What we typically counsel all of our clients is to ask yourself if the communication is relevant. Is it something that is needed at that time? And if so, you should send it. If it's just something that maybe could be delivered another way or put on a message board for people to get to later, then make your decision. We just encourage people to use relevancy as the filter to answering that question.
Okay, relevancy. Again, not a very good quality for a lawyer, because we're not very good at being relevant. But Chris, you're the guy on the front lines as the administrator of a center. I liked your comments about being inspirational, but I started to wonder, and also Mary Ann Monroe, my partner, mentioned to me this thought. Can you be inspirational like too much? Can people start to feel, wait a second, you're treading into weirdness, maybe spirituality or something like that? Is that a concern? And if so, how do you guard against that?
Yeah, so we made sure to keep it secular as far as our messages go, and more than anything, make sure that they know that we were thinking about them. I had a lot of employees that because of our volume, they weren't at the center anymore, and that they weren't able to work, and that they were still on our minds, that we were looking forward to them coming back, and we appreciate all the hard work that they do, and that they truly are heroes to us.
Right. It's great. It's something that I have to remember to do here. We're all so busy, we forget that people are not in the best state of mind these days. Okay, Brandon, you threw out a very practical problem, which is that you could send out messages, let's say to patients, and they could be unread, unreceived, moved, whatever. How do you get a list of those? And should an organization have somebody whose job it is to kind of keep track of that, or whose responsibility should that be?
Yeah, the communication is something that needs to be monitored. The beauty of leveraging texting as a communication channel is you can see if the text was delivered to the phone, and you then just follow on the behavior of most American adults. Most Americans read a text within 3 minutes. So if the technology tells you the text is delivered, you have a high level of certainty they're going to engage. You can also ask them to respond to a question. But the technology itself, if you can look at a screen and see who got the message and who didn't, it lets you know how you need to risk adjust. Who do I need to call because the text didn't get delivered? Whereas when you leave a voicemail or send an email, it's kind of a game of hope. You hope someone gets it. You hope it doesn't get stuck in a filter, spam filter. So having technology tell you who's engaged and who's not, lets you decide how to take it further. So.
Okay. All right. Last one for your session. By the way, guys, we're probably going to go over, but our techies tell us that that's okay. So hopefully you didn't schedule anything right as it ends. But the last one's for Chris. Chris, you made a comment that stuck with me. I've spent a lot of time together with one of my partners on now, Stacey Gulick, working on disaster plans. Then a disaster hit, right? And you made the point during your presentation that pandemic was not one of those that was high on your priority list. So I guess my question is, were those plans helpful? And are you going to have to take another look at them and say, let's start again?
So I feel like the plans were helpful. Again, not something that we were necessarily had high on our list, but it was on our list. And so we did have something in place to be able to mitigate that or to respond to that at our center. The thing that we weren't really expecting, and with most disasters, is that disaster happens, you have your response, and then you're done with it. And here we are, 9 months later, still dealing with this at this point. And that's something in our disaster plan that we don't really had not planned for. So that is something that we have looked at and have sort of changed. We didn't have to necessarily reinvent the wheel with it, but we did have to sort of tweak some things for if another situation like this ever would occur, or an ongoing disaster that would last longer than what we were expecting.
Interesting. Okay, we'll look at those plans. Okay, we're going to go on to the next session, which was how providers collect the revenue during COVID and beyond. We're joined by the speakers for that, Andrew Harding, Vice President of Customer Success at Rivet, and my partner, Deborah Silverman, who heads up our managed care group. Andrew, I'm trying to find, why don't you wave to me? There you are. Okay, gotcha. So, hey, see, it's hard. It's easy when the speakers have the same name as me.
Exactly.
You changed it. Very appreciative. So you described the problem, which I actually checked with a couple of other clients, said the same thing, that there's this rising amount of patient uncollectible amounts. And it's used to be just something that was there, and now it's something that's threatening. And one of your slides was very surprising. You said in the slide that 83% of small practitioners, not sure how you're defining small practitioners, but say that the slow payment of high deductibles are one of their top challenges. So my question to you is, should you then make a business decision about maybe not accepting high deductible plans or pushing back on payers who offer those plans if it's such a rising challenge?
Yeah, there's kind of two quick parts to that, or I should say two segments of these rising deductibles, one of which are specifically so exchange plans or expansion plans that are maybe, silver, bronze, almost catastrophic care plans that you can opt out of the network for payers, and that, that's a business decision. The other kind of cohort are, traditional commercially insured patients, your PPOs, your HMOs, your POS plans, that it's actually really difficult to, one plan may have dozens, hundreds of different deductible levels that are set by the employer that is either funding the plan or the fiduciary payer that's taking that on. So kind of splitting those helps you understand that, hey, if there's exchange plans, we may opt out of these type of networks because maybe they don't compensate well, or even if they do have good compensation, they often have such high residual patient liability that it can lead to some pretty rapidly ballooning patient AR. And then the other is the more commercially insured, they may be traditional PPO plans, but they may still have high residual patient liability. So there's going to be a fair amount of time and effort to segment out when you're verifying benefits. And honestly, I don't actually know from a compliance standpoint if you can differentiate between patients that have high deductible plans or not, if they are in the same network or plan type as maybe some of those lower deductible patients. That's what I would look at, is definitely consider the plans and networks that are in your area, and then think about if that's a business decision you want to make to exclude yourself from some of those networks.
Okay, so you mentioned compliance. One of the issues that we've had is payers who are going after providers more than they used to, where they say, well, you weren't collecting those amounts, right? I know, of course, none of our clients would ever be accused of that, but let's just say hypothetically that were to occur, right? So you mentioned in your presentation, it's not enough to just send out letters. I mean, it's not effective to send out letters. I've had clients say, well, the Medicare rule is if you send out so many letters and you don't get it, you've done your duty. But your point I took from your comments was, well, let's try to actually collect them and do a better job. So you talked about not just sending the letters, but introducing actual contact points that are verbal, I assume. Could you talk more about that? I think that's helpful.
Yeah, and this maybe touches a little bit on what Brandon was speaking about with just different touch points and the relevance of the touch points. Phone calls alone are actually quite expensive, right? There's a range of the cost, but generally it's estimated about $8 to $10 is the cost of a phone call out to a patient. And so you look at more cost-effective solutions for collecting from your patients, and you have things like automated e-statements that are generally coming at a price tag of maybe 20 to 30 cents instead of the actual statement cost of 80, 90, $1. Same thing with SMS and text-based communications. That engagement that Brandon mentioned about, read a text within 3 minutes and relatively high engagement rate is also a really cost-effective solution to automate the balance reminder process. And then, one additional thing that you can think about is the automated card on file payments that just get generated without the patient having to actually take an action. They set it up in advance, and you go through the PCI compliance, of course, but you go through the process of having that card on file and being able to notify the patient of a balance and charge those cards. So those are probably three highly cost-effective solutions relative to waiting for the patient's next visit or doing very high-cost outreach.
Okay, by the way, if you're going to start cross-talking to other panelists, I'm going to lose my mind. You mentioned Brandon. All right, so let me pick on Debbie, your co-presenter and my partner. So there's a simple question I asked myself listening to your presentation. Deb, why don't we just collect the deductibles up front and avoid this whole problem that Andrew is describing?
Well, it would be great if you can, but the problem is you have plans that expressly prohibit it. And unlike a copayment, which is the amount that a patient has to pay at the time of service, deductibles are calculated based on what's in the queue. And we've had fights with plans, including Empire Blue Cross Blue Shield, who has actually come down on one of our clients saying that you cannot collect a deposit based on an estimate. You have to let all the claims hit the deductible so you know exactly what you're collecting. Not all the plans are that aggressive about it. I think United will let you take a deposit provided that you, one, won't refuse to treat somebody who refuses to give you the deposit, and two, if you over collect on the deductible, you turn that money around and give it back to the patient quickly. You don't sit on it for 90 days.
All right, well, so much for my simple idea. Deb, is your department and our compliance department, are you seeing an increase in audits from payers? Are they becoming more aggressive towards providers?
Absolutely. We practically have a cottage industry dealing with clients who've been audited both by the feds, the state, and by managed care companies.
Okay. And so what type of things do we just lay down? I hope not. Do we push back? Do we fight?
Oh, of course, of course. I mean, it's essentially what they're really looking at is failures in documentation. That's probably the largest area that we're seeing right now. I think just OMEG, which is the Office of the Medicaid Inspector General in New York, collected over $23 million for lack of proper documentation. So there are ways that we work with clients to protect them on the front end, how they respond to medical record requests, what they should be doing to make sure that they are documenting properly, that they're getting prior authorization, that they're coding correctly, and then, of course, whether or not the service is medically necessary to begin with. The biggest area that I'm seeing right now has to do with medical necessity based on site of service. So where it could benefit our ASC clients because plans are moving business away from hospital settings to the ASC setting, it can hurt the ASC if plans now want to push services out of the ASC into doctor offices.
Okay, great. Okay, we're only a couple minutes behind, so I want to move on to the next session, which scared me very much. It's about what facilities should be doing about OSHA enforcement. I was one of the people who very, dismissively said, how am I going to get in trouble if one of our clients has, let's say, a nurse or whomever, God forbid, says, I got COVID here. You could have gotten it when you went and drank, a tea at Starbucks, coffee at Starbucks. But after watching this, I realized that that was naive. And we learned a lot. And if you haven't listened, go back and listen to Todd McDonough, Principal and CEO of Healthcare Compliance Network, Wix Moffitt, Principal and Executive Vice President of Healthcare Compliance Network, and my partner, Sal. So, Wix, can you tell us, for those people who might not know, what exactly OSHA's role is in the world and what prompts an OSHA audit?
I'm going to defer to Todd because he's dealt with most of that in our company, right on the front lines. So, Todd, can I defer to you on that one?
Yeah, sure. Probably, and it's hard to say what percentage, Andrew, of the complaints that come through to OSHA are driven by individuals, but most of what is coming through, and certainly what we're seeing in a lot of the cases that have come across our desk recently, just because the overwhelming amount of information that people are just ingesting on a daily basis about COVID, it's created an opportunity for these employees and actually now patients, for the most part, who are feeling like if a group is not doing what's necessary for them in regards to safeguarding their work environment or safeguarding the ASC, the hospital environment, the physician practice environment, you name it, then they're going to get on the horn and call OSHA. And that's, I think, why we've seen such a big abundance of what's going on. And when that happens, obviously OSHA has got to react. There are the log information that gets put in on an annual basis, 300 logs that obviously OSHA will go through, peruse those, try to get an understanding where there may be some areas that they've got to identify, and then they'll go back in the following year and randomly go and look at those areas, whether it's a nursing home environment where they're seeing the incidents and accidents, or if it's a hospital environment, ASC, doesn't matter. There's a percentage of information that they're getting where they're going to go back out and they'll target that area to see if there's a way for them to get out and help mitigate that process.
Okay, so give me, whether it's Wix or Todd, give me the 2-sentence what's the 2 or 3 things I can do to make sure big bad OSHA doesn't come flying into my facility?
The first thing that they need to do is have a bona fide OSHA program, which covers all of the elements that are under the general duty clause. That requires them to have that manual that covers that covers fire and life safety, that covers bloodborne pathogens. Now it has to incorporates COVID. They have to train their employees. They've got to make sure that information is available if asked. And they have to continue to keep that process sort of evolving on a regular basis within their practice.
Okay.
Andrew,
All right.
can I give you the 2 words, documentation, training?
Yeah, please.
I mean, I can elaborate, but you want to have your documentation
Oh,
together?
yes, you were taking me literally, and I'm not going to
Yeah,
check.
I was being a wise guy, sorry. So that's that, and a good reporting structure, because if there's a problem in your organization, and I went through the 8 elements of compliance, and one of them was reporting. If you have a hotline and you have a compliance officer and you have an issue in your facility and you have someone to report it to, chances are they're not going to drop a dime and call OSHA, if anybody even remembers what drop a dime means. So that's really important to keep it within your own walls. So having all that structure in place,
Okay, great.
Helps a lot.
Good. All right, Sal, let me remain naive for a second, okay? So OSHA comes in and they've gotten a complaint from one of our employees. Clearly not anybody at GW, but this is theoretical, okay? And they come in and I say, hey, it's impossible that they got it here because, you know, maybe they got it from the kid's teacher, maybe this, maybe that. How's OSHA going to respond to that defense?
So that's a great question. I think it's something that plagued a lot of facilities and employers across the nation. It's not specific to our region, but everyone's reaction was just like you said, Andrew, you can't prove it here. And I think factually that's correct. I think the science also supports that. How are we supposed to determine and pinpoint where someone got COVID? That said, OSHA didn't want to hear it. And I think personally it's very politically motivated that they had to take a stance to demonstrate that we're going to protect employee safety. That's our primary focus for this organization and nationally. And the response we got back from OSHA was, well, there's a requirement that you log it and that you disclose the information. And as they went through the months of COVID, they finally put out some guidance that said, well, if you want to say that it didn't happen at your facility, you need to kind of meet this checklist and do an evaluation internally to point to some other outside factor. It's really a more likely than not standard, that it was more likely than not that they got COVID somewhere else. So, you know, we've been working with clients now on what seems to be a daily basis, going through that analysis. The burden is somewhat on us now as employers to say, okay, they got it at church, they got it at synagogue, they got it at the gym, not here.
Okay, scary. So you're seeing an increase in the amount of calls we're getting about OSHA enforcements?
Generally, yes. I mean, you have it coming from 2 ways. One, employees are just afraid because what they watch on the news and say, you know, especially at healthcare institutions, I don't have enough PPE. I don't have a N95 mask, and they're calling OSHA. And then the employer has to respond. And it's very important that the employers keep in mind, and your ASC in particular keeps in mind, there are a lot of nuances here. And OSHA's in a bit of, I believe, uncharted territory for themselves. They're usually on construction sites dealing with asbestos, easier issues that you can put your hands around. Now we're talking about very highly complicated issues, respiratory programs, fit testing, medical evaluations, and reporting requirements. So the best thing you could do is get your hands on that information, talk to consultants, advisors that deal with that and know the ins and outs. And you're going to have to explain to OSHA and make your case why it either doesn't apply or why you are complying with what you have in place already.
Got it. Okay. That's scary. Moving on to something not as scary and maybe more value in terms of increasing value. We had a great discussion about really the value in equitizing centers. And I know physicians call all the time, how much am I worth? So if your physician owners didn't listen to that session, you should get them to do it. And we had Max Rebo, President and CEO of the Coca Group, and Bob Getling with the Bloom Organization. Max and Bob, you both explored different paths towards sale, but and Bob, you also focused on the impact that COVID has had. You put up a slide which really shouldn't have been surprising, but the fall off was that between March and June, I think the slope of your graph went straight down. So let's start with you on that impact. Do you think that after what's happened, that private equity will recover completely, or have they been like kind of damaged in their view of things, or more chased these days? What's your view? Wait, you're still muted, Bob. We can't hear you.
Now, how's that? Can you hear me?
Now I got you. Okay.
Okay.
Our first glitch.
So it's interesting. I was saying that before COVID, from a healthcare services, the doctor business, ASCs or practices, everything was already evolving. And so, COVID obviously brought, that in that graph, you could see where deals from March to, May or June, they just fell off completely. And specifically private equity, that's what's hot, right? That's what's hot on the private equity deals. The thing to remember though, and we saw this at the beginning and see it now too, that private equity guys are out there, they got a bunch of money, they're very smart, but if they don't do any deals, they ain't making any money, right? So they got to do deals. And so, after the couple of months, they started, everybody started getting really itchy on how to do deals. So what it turned to was more of a figuring out how to do it and how to allocate the risks. And so I see private equity back, even more, again, with it in a different environment, even more needing to do deals because they spent 3, 4, 5, 6 months not doing anything. And, those guys got to do deals to get a paycheck.
Right. Okay. So you think it's going to come back, but does it come back exactly as it was, or do you think there are some changes that are going to be made?
Yeah, no, it comes back. But again, remember, it was changing before. And so
right.
the change is what's constant, right? But now from a structuring perspective and getting, the objective now is you got a willing buyer and a willing seller. Okay, how do you get the deal done, which really comes down to allocating the risk, right? If you're talking about COVID, how do you allocate the risk that you're not going to overpay, right? Or that it's going to, that the valuation is going to be what it was. That's where the real brain power is going into that and figuring out, as you guys see doing these deals too, that, things that even before COVID were an absolute no-no from you guys, the lawyers, for example, an earnout. Now, in the private equity world, earnouts are standard.
Yeah.
And you guys, the smart lawyers, are the ones to figure out how to do it, call it something different, get rid of the regulatory issues, but make it a tool in the toolkit to getting a deal done.
You're not suggesting that lawyers are anything other than honest, but
Not at all.
I'm going to call an audible here. Max, somebody in our studio audience asked a question. They mentioned that in one of your slides, you referenced that there's a 10-year penalty. Like if a physician leaves earlier than 10 years, there are penalties as a way of kind of dealing with some of the things that Bob was talking about, the risk. What the question is, can you describe like what some of those penalties can look like?
And the question, Andrew, is related to a PE transaction specifically?
Yes. Yep.
Well, I think it's mostly financial penalties and related to the equity that they retain, the rollover equity, and how that might be structured going forward in the second bite of the apples, we call it, I think where the question might be emanating from. So clearly, it's not a penalty, a regulatory thing as such, and I don't think that's what the questioner's referring to. nor was the slide. But I think the risk is that the deal would change somewhere down the road, or there would be some different criteria for selling off the rest of their equity in a private equity deal. And so, you know, I agree with Bob that the rules are changing somewhat. Private equity is a dynamic industry to begin with. It's been around, but then again, it's been more prominent more recently in healthcare, as you know. And so I think whether we had COVID or not, we're seeing deals evolve and change as it were. I'll stop there because I know there's other questions.
Yeah.
You have.
One more question for you. We're seeing doctors call up as a result of COVID. People who said, I will never sell, blah, 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 blah. I'm not going to a hospital. You talked in your slides about hospitals, also private equity, and suddenly that's changed, right?
Yeah.
Yeah. I was wondering if you're seeing the same change, and can you talk about what some of the factors that might be going into that are?
Yeah, interesting dynamic. And when it comes to hospitals, they're trying to stay in competition with private equity, particularly as private equity looks more and more at surgical practices. Obviously, the theme of your conference with ASCs being a major part of that transaction. And so hospitals are definitely trying to stay competitive. The challenge that we're seeing in our consulting practice is that community and rural hospitals have been so negatively affected by COVID that they are having a hard time keeping up. Now, you know, you might say, well, private equity won't be as interested because the groups aren't as large in rural communities, and that's true. But I see the biggest challenge for hospitals in that arena, the larger hospitals, the health systems that are in the Northeast and, well, all over the country where we work all over, you know, I don't know that they've necessarily cut their budget on the deals that they would do to try to stay in competition with private equity. But clearly, the rural hospitals are the ones that are struggling. And if you go down to the critical access hospitals, they are hanging on by a thread as such, many of them. So I think we've got some real challenges there, and they're going to be hamstrung, and as well as in recruitment. New physicians into their communities. They've always had a struggle, and it's going to be even worse.
Okay. Last question for your session, Bob. Question. I'm looking to sell now. Would I be better served at going with a private equity that is not necessarily focused in my, let's say, orthopedics, not necessarily focused in orthopedics, or somebody who really is in my niche, or doesn't it matter?
I think the answer, it depends, right? I mean, every deal has its unique characteristics, right? Every market has its unique characteristics. There may be a situation where a private, in a particular specialty, a private equity firm without experience could still be the right answer, or, the absolute reverse. Somebody, or a private equity firm with all that experience could be the wrong answer. Right. It just depends on a whole bunch of, it's a whole soup of issues that you got to put together and sift through to find out at the end of the day what's the right answer for that particular, practice, surgery center, whatever it may be.
So you would say also due diligence on your potential buyer.
Yeah, absolutely. Yeah, but even more than just due diligence, Andrew, it comes to a whole comprehensive assessment of all the factors. And, by doing that, we always tell our physician clients, hey, docs, no disrespect to docs, but they love to jump to the end. They must read the end of a book, and then work backwards. That's just the way they are. But we always tell them you can't do that in this process. You got to go through the process. You got to turn all the cards. If you do it that way, then at the end, you will have addressed all the factors, and the right answer will be there. But you can't. It's not something you can just jump to the end of.
Okay, great. All right, so we're all on the computers, and after listening to Nelson Gomes, Senior Vice President of Business Development at Medicus IT, and my partner, Stacy Gulick, I feel like we're doing something evil because it's very scary what seems to be seeping out. But besides being scared by Nelson's description of all the different ways that people are trying to mess up your life, Stacy outlined a very aggressive Office of Civil Rights even during COVID. So Nelson, I just have kind of a basic question for you. Given that the emails seem to be, with the phishing, such a huge exposure area, is it time to just take some kind of radical views, like if you're working in a provider, only EHR emails, stop emails entirely? I mean, can we still use emails given the devastating effects of some of these attacks?
Yeah, I believe so, and it's a matter of how you're going to use it, right? There's plenty of methods on how to do it and do it securely. I would say anything that has PHI or any type of sensitive information, whether it's financial or operational, that's specific to the facility, encrypt it. Part of your nowadays, if you have email, you have an encryption module that comes with it. Encrypt, encrypt, encrypt. That's your easiest way, your safest way to communicate using email. So any information, whether there are attachments or not attachments that they may have, that you may want to communicate with someone outside of your organization, leverage the tools that you have. And encryption is a big one for sure.
Okay, so here we are collaborating, on GoToMeeting, and you mentioned these different platforms. Are there any that are particularly worrisome to use? I know Zoom in the beginning, everyone was talking about what they call it, Zoom bombing and stuff like that.
Yeah.
Speak to that if you can.
Sure. So using collaborative tools, especially in this day and age of COVID, is going to continue to be something that's going to, is leading edge, and we're seeing, like you had mentioned with Zoom and Zoom bombing, yes. That was definitely an issue. We're seeing that a lot of these technology firms are really taking it very seriously, where they're using now encryption within their platforms to ensure that security type. And one of the best things that I always share with our clients and those that are using the products is to make sure that you have done your due diligence through the process of evaluating your product and making sure that how communication of that product works. I go back to what I said in emails. Nowadays, we're on a GoToWebinar right now, and it's an encrypted, webinar. So that's going to prevent any type of Zoom, bombing, as you would say. Same thing on the Zoom side of things. Office 365 now with Microsoft Teams is also encrypted. So there's a lot of tools that you can use collaboratively. Just make sure that you evaluate the right tool to use. There's Google's platform. And to be quite honest, I'm not a big fan. WebEx is another product that's out there. Cisco is known for their high encryption. But yes, we're seeing a better improvement on not only on the quality, but on the security of these products. So if you're going to use a product, make sure that you go through that due diligence evaluation process for sure.
Okay, great. Stacy, Chris, listen to this next question. It's going to affect you as the provider. Stacy mentioned in her slides that OCR is fining people hundreds of thousands of dollars for delaying one patient's record. In other words, the patient asked for it, and there was a delay in getting the patient their record. Can you imagine that? Chris going and explaining to your boss, well, we have one record, and now we owe $400,000. It's crazy. So Stacy, that I couldn't kind of get over that risk. Are there some things that can be done to protect, obviously get it on time, but let's say you're in danger. Can you get an extension from the patient or anything that you could think of that would work?
Well, the number one thing I would recommend is that if the OCR sends you a letter and says, send the patient the record, send the patient the record. Half of those settlements resulted from people who received notification from the OCR and ignored it. They're amazing, right? In fact, we had a couple clients do that, honestly. So the other thing is so if you find yourself in you shouldn't find yourself in a situation in which you can't respond to a patient within 30 days. That seems kind of ridiculous to me. But if you do, HIPAA allows you to be able to send a letter and request, tell the patient that there'll be another 30-day delay. Yeah, so that is a permissible response. As long as you get that letter out within the first 30 days, you can take another 30 days. But more often, what I'm seeing is that one of two things. One, that it's just human error. The receptionist is thinking about her date that night and puts it underneath the pile that gets thrown away and so forth and so on. So it's hard to protect against those human error type things. The other thing is what I'm seeing as the underlying story behind a lot of these settlements is they don't want to turn out the information because it reveals med meth. And the government, between this initiative to allow patients access to their information and the information blocking rules, that is not going to be tolerated. So you really do have to turn over all the information in a designated health record that is requested by the patient.
Okay. All right. So I'm sure that everyone on this session has worked from home, right? Stacy, are you seeing that working from home is being attributed to a higher security issues? And is there things that we can do beyond what Nelson said on his session to protect us?
Well, certainly the FBI, the OCR, the DHHS, New York State Department of Health, New York Jersey Department of Health, all those letters that we speak to every day, I think, are telling me that there is an enormous uptick in cyber attacks. And some of you may have seen everything that's been published about that. So yes, there is a lot more attacks going on. That actually was kind of starting before COVID and then just seems to have accelerated exponentially. So a lot of what people need to be doing to protect during this time is the same as what they should have been doing before, but a little bit more accelerated. I cannot tell people often enough, and I know I said this during my presentation, but I'm going to repeat it. You can't click on attachments from people you don't know. That is really the number one way that either ransomware gets into the system or they put in some type of malware that copies your emails and steals your financial information, or they get your credentials and they're able to use it in other ways. So number one, educate your staff and remind them. You should be sending out cybersecurity alerts all the time, reminding your staff. One, it reminds them. And two, if the OCR comes knocking on your door and you can provide evidence that you were ongoing educating your staff, it will protect you. Two, you still need to be really diligent in your backups. In case you get a cyber attack, you can rely on your backups. And finally, the last thing, and I know we're in a hurry, is to buy cyber liability insurance.
Yes, good, all good. All right, I'm going to move on now to the fun world of HR. And there was a session that I found very thought-provoking also. It's how 2020 and COVID-19 have impacted the employees of providers and how should we respond. We had on that and on this session as well, Tom Jacob, CEO of MedHQ, Rita Hernandez Fiji, the CEO of MedHQ, and my partner, who's head of our employment law group, Marianne Monroy. So Rita, I'm going to start with you. Everything at GW is wonderful, but clients are our clients are calling and talking about how there's a lot of staff conflicts. I mean, it seems like every day there's a physician who didn't speak right to a nurse, or two people at the same level who feel that it's a hostile place, and we've already talked about the OSHA issues. There's so much seeming tension, which leads to call us, which I guess is not a bad thing if you're a lawyer. But Rita, I'm obviously your company deals in HR all the time. Are you seeing the same kind of spike in those issues? And if so, what do you think we can do to lower the temperature?
No, we are seeing the same kind of angst amongst people. And I think it really is, it boils down to angst. People are very tense, people are very nervous. And again, we encourage open dialogue, town hall meetings with your groups. What can you do? What's happening right now? And then, of course, always addressing the issue sooner rather than later, because while it may seem like two people in a bad mood today, these things tend to spiral. So we certainly recommend talking to the individual separately and apart. but really bringing it home, that everybody is under stress. You're not the only one. What can we do here in the workplace to facilitate communication, but also laying out the expectations for communication? I think that's vital. No matter what you do, you're responsible for your words. And so reminding people that there is a responsibility here to treat each other with respect, because the more friction there is, it just escalates and it doesn't get any better unless it's addressed. You can't expect it to go away on its own.
So taking the theme of Brandon, communicate quickly before it becomes
Yes.
a problem. Okay. So on that, Tom, you mentioned not being a mental health professional, and that kind of like stuck with me. Again, everything is wonderful here at GW, right? All my partners are on the phone, but you do sometimes find yourself, you're talking to somebody and it becomes very mental healthish, right? How do you deal with that? Any guidance to how to turn it away from that, or do you just plunge forward?
Yeah, that's a great question. So we don't want to be in a position of acting outside of our scope of competency, right? So even though we're in healthcare, we can handle many things. We're not, trained to do all things. We're trained to do specific things. So depending upon what that, if an employee comes to us and we're a manager and they are breaking down, so to speak, depending upon severity, don't be a hero either. If you feel like if you feel the situation unsafe, call for help. 911 or emergency services as appropriate. But most of the time, it's going to be a softer issue. So in those cases, get other people that can help you out, such as HR department, if you have an HR department, or maybe you have an HR services firm if you have a PEO, or you have even your attorney or perhaps your broker services that supplies your employee benefits. And the reason is because they're going to be expert in how to guide that employee in a confidential manner into how to access services that can help them out in a whole range of severity. So something that might just take a phone call to a provider, or something that maybe needs some ongoing care, but having somebody who knows your benefit programs really well and can guide that employee to those resources. Lastly, I just say that we can get ahead of this a little bit by maybe using something like Brandon's service of text messaging or other communication methodologies. Continually provide information to your staff about what your benefit programs have in them. What resources are available through your benefit programs. If you do that on a proactive basis, then maybe you won't get the encounter with the employee. They'll know, what, I know I have this benefit that my employer has provided for me, so I'm going to tap into that.
Yeah, that's a great thought, and maybe you attach it to one of Chris's inspirational messages about letting people know, these are tough times, and here's a resource that we all have it in our plans, but we kind of shy away from it. Good question. Okay, so speaking of desperate HR situations, poor Marianne, who gets pulled in every day from providers. Marianne, what if an employee says, I can't come to work because of childcare issues, or I can't take public transportation? Is there a time that you can push back and just say, listen, we got to run a business, or where is that balance, or is there no balance?
Right, so it's something that requires a dialogue with the employee, and which is the case in so many HR situations. You have to sit down and get more information and understand all of the facts, because there is a legal aspect to that request as well as a practical one, okay? And from a legal standpoint, there are certain benefits that the employee could be entitled to. So when the Families First Coronavirus Act came out, that provided for a benefit related to if you needed childcare or needed to be home for childcare, or your school was closed. Right now we're in the stage where most of the kids went back to school, but now a lot of schools are either on hybrid, or I think I heard recently that this New York City schools, right, are closed down right now. So that's going to come up again, the FFCRA. You know, as healthcare providers, there is an option, and we talked about this during the session, to exempt out direct care providers, not all employees. So, you know, the employer might say, all right, there isn't automatically an entitlement to give an employee leave because their kid is not in school, right? Or childcare issues. But then you bounce back to the practical standpoint. You've spent a lot of time recruiting staff, investing in their training, you know, and they might be critical, talented employees that you're not prepared to just automatically let go. So, you know, we've been working with clients to really, you know, try to find some flexibility, but you do need to run a business, right? So if they're critical staff, they really can't do it, they're not eligible for the leaves, or maybe they have exhausted the available leaves, you still have to be able to provide the patient care services and operate the business. But if you do choose, or if you're able to be flexible, you want to make sure that you're doing it in a non-discriminatory fashion, because that's where I then run into, or our department runs into issues, because you let some people work from home or flexible hours and then not others. So you really have to have some objective criteria when you're dealing with the return to work, or exceptions being made for employees that have childcare issues or school related issues. So it's not, you know, a bright line rule. It always comes down to the discussions. All right. And the same thing with public transportation. You know, the employer's responsibility is to provide reasonable disability related accommodations. You know, general fear at the start of the pandemic, people just didn't want to go to work. A general fear is not going to give you leave entitlements. But if you have a medical condition or a health condition that warrants, you know, some type of cautionary quarantine or restrictions on your, you know, ability to go to work because you're at higher risk, then you have to consider that. Now, it's not really about how you get to work, but if the employee is saying, I can't get on the train because I am high risk, that's where you're going to open up the door to the disability conversation. And if they give you a note that says, look, my doctor says I really need to, you know, self-isolate or quarantine, or I'm at high risk, and not only am I, you know, not able to really get on public transportation to get to work, at work, I'm vulnerable. That's where the accommodation discussion has to come into place. So you can't automatically, you know, dismiss the request out of hand, especially if you know that the person falls into a high risk category. So that's what we're seeing, quite a bit of these different questions about employees not wanting to return to work, and taking each one individually.
All right. Wow. Very complicated. I'm glad we have you. All right. So on to the last session. So there was a lot of money that was stimulated and injected into the system through the CARES Act funding. And we heard from Dan Mayo and Dominic Segala from Witham, who provided an outline of those programs, and Kim kept them honest with some moderation. So Dan, I'm first of all going to ask you an audible question, which I thought of as I was walking down into this room with the backed out sign behind me. The question for you, Dan, is, so here we are about to go through an administration change. What does that mean for the PPP program? You know, I saw what happened with Obamacare in the years of fighting. I understand that that was a congressional plan, but can you guess, and that you can't be wrong because it's a total guess, can you guess how the PPP program might be impacted by the new administration?
Yeah, I mean, it's a good question. I think the biggest impact would be any changes to the program, right? Whether they would make the PPP amount tax-free as they intended in the additional stimulus legislation. I think that's going to be the key. And whether they issue a new round of the PPP, both of which were in the HEROES Act, which was a Democratic proposal. There are two versions of the HEROES Act that were proposed. Obviously, the Senate is calling for a skinnier version of stimulus legislation. The parties are at a standstill. I read an article today calling the outlook bleak for the next stimulus legislation. So it may be that we have to wait for the January 5th runoff in Georgia to see what happens to those 2 Senate seats, to see whether the Democrats get control of the Senate, and can control Congress when Biden is sworn in on January 20th.
So wait, I got to follow up on that. This is complete audible. And of course, that's nothing to do with my own selfish interest. But you're saying that there's a chance that the PPP loans could be considered to be tax-free, meaning the forgiveness wouldn't result in tax to you?
It's a possibility, but they would need legislation to affect that. So if Congress has the will and the desire to pass that, they could. Whether it happens is anyone's guess.
And do you think that if everybody in the conference prays for that, that would increase the chances that that would occur?
Absolutely.
One more question. So we're getting this a lot. In fact, we've asked you this as our advisor. Should we wait or just submit it now for the forgiveness?
Yeah, that's a good question. I mean, there's very few industries where submitting makes sense. There are some public or private schools where there's a non-tax or there's a regulatory reason outside of the PPP to apply early. Other than that, there's no reason to go early, generally speaking, because the payments don't start until 10 months after the end of the covered period. So if you go early, it's just a matter of the psychology for most of our clients that do that is they want it to be done with and they want to get this forgiveness decision as soon as possible. It will have no impact on the tax treatment. It is going to be taxable. Our view is that the expenses are disallowed in 2020, which is consistent with the IRS notice that's been published. We do expect additional guidance from the IRS in the next 2 to 4 weeks, confirming that timing. And if they hew to their previous guidance, it will be that the deductions are disallowed in 2020. Having said that, to get back to your question, the one key point for borrowers with loans over $2 million, there may be a reason to apply not so much early, but to use an 8-week covered period instead of a 24-week covered period. And that is that new 3509 form that's come out. It only applies to borrowers of loans of $2 million or more. And that's where the IRS, I'm a tax lawyer, by the way. That's why I keep saying IRS. That's where the SBA is really getting at whether the borrower was eligible for the loan in the first place, whether the current economic conditions made the loan necessary at the time the borrower signed the loan application. And so that question, that 3509 that came out about 4 weeks ago now, that form inquires about dividends, distributions, payments of salary in excess of $250,000, and it looks at dates from mid-March to the end of the borrower's covered period. So if the borrower had a large capital campaign, they acquired assets, they paid large salaries, they paid big distributions, after their 8-week covered period, but before the end of a 24-week covered period, they may be able to minimize blowback from that questionnaire by using an 8-week covered period instead of a 24-week covered period. The questions are really improper, and we understand some lobbying organizations are lobbying the SBA to retract the form and modify it. Recall that that was the certification made on the loan application, the PPP loan application was made as of a date specific. It's a moment in time certification, and it's based on your good faith belief of what the future was going to hold. And so what in fact materialized over the next 8 weeks, is marginally relevant to determine whether you had a good faith conclusion. This was a once in a lifetime pandemic for most people. No one knew what to expect. So the fact that someone's expectation didn't turn into reality doesn't mean they didn't have good faith when they signed the document.
Great. All right. So my takeaway is that you promised us it's tax-free. That's what I heard. So now
there you go.
Dominic, we're going to ask you just one question. I'm getting a lot of confusion from people about what exactly is the time frame to pay back their loans received under the Advanced Accelerated Payment Program. Can you just be very pithy, because there's a lot of confusion. What are those time frames?
Absolutely, Andrew, and thank you. So initially, when this came out, clearly the objective was to put cash flow into the provider and healthcare side, and it worked. They put $100 billion out there in a quick period of time, and it was really the first stimulus of funds going to the providers. Initially, everyone thought the payback would have to begin in August. August came around, that didn't happen. So people knew there would be some type of extension. In October, there was the pass of the Continue Continuation Appropriations Act, which basically amended the repayment terms. So a lot of people now here, you have 29 months to pay it back. So I'll be very specific about that. So the first is 12 months. You have 12 months from the date you received the distribution or the loan that you don't have to pay anything back, no interest. After that 12 months, CMS has the right to take back for the next 11 months up to 25% of your loan. So let's make it simple. You had $1 million, they can recoup over those next 11 months, $250,000 or 25%. So there's your 12 months plus your 11 months. At the end of the 11 months, there's a 6-month period. So 12 plus 11 plus 6 is 29. During that 6-month period, they, if you still have an outstanding amount, can take up to 50% back over that 6-month period. Now, at the end of that 6-month period, if you still owe funds, interest begins on the end of the 29 months at 4%. So it's not compounding from the beginning, at which point CMS will send you a letter stating you owe X number of dollars, and the 4% interest calculation starts now. So I think the big takeaway, Andrew, is it's 29 months. They're not going to take away your full Medicare reimbursement. And it's the first 12 months, no payment, the second 11 months or the next 11 months, up to 25%, the last 6 months, 50%. And then if an amount is still outstanding, interest begins at that point in time.
Thanks, Dominic. That's still going to be painful, so we'll tell our bankruptcy department to get ready.
And if I could just note, there is a lot of noise and lobbying around in the next stimulus bill of potentially converting these loans to grants. We continue to hear that. Clearly, if this, phase 2 of COVID has the impact we think it may, this could be part of another stimulus bill, which would be very favorable to many providers.
That's why everyone hates lawyers, because we win either way. If it's grants, then they'll have money that they can pay our bills. If it's not, a bankruptcy department. So it's all
right.
Fine. All right. So listen, we've covered an incredible smorgasbord of ground. And I really, if you're out there and you're listening to this, whether on YouTube or listen to it live, our speakers did not get paid. They contributed their own time. So use them for questions and services. We will be sending around a link. By the way, all the speakers that are on, unless I hear back from you, I'm going to assume that you're okay with us giving your detailed contact information, and also that we can share all your slides. That'll be going out, according to our Director of Marketing, by 8:00 a.m. tomorrow. And you can listen to it. They're going to be making it into a movie. I'm not quite sure who's playing Brandon, but we'll see what that's about. But I really want to give a special thank you to Kim Kempton, Greg Bloom, for their, my partners, for their specific help in getting this crazy idea I think I had, but it worked. A really special thank you to Miguel, who really was our technical person who put this together when some people told me just to abandon ship, and Linda and Mandy, our Director of Marketing, and to everyone else who really made this happen in like 3 weeks' time. I'm really pleased. I think we're going to be doing a lot of these. Look, we learned from COVID, and let's all pray that we stay safe and healthy and that these vaccines work. So we won't be talking about lessons from COVID. We'll be talking about other things. So have a great day, and thank you for making this incredible educational experience. Take care.